Atrial fibrillation is very common, and we have very effective treatments to prevent stroke related to atrial fibrillation. About 1 in 5 strokes are due to atrial fibrillation. But these very effective treatments are not used consistently. In fact, only about half the time are they used, and the reasons they're not used seems to primarily relate to the aversion of risk, to this concern about bleeding that's way out of proportion to concern about the stroke, and to eagerness to prevent the stroke as part of what we do. We designed Impact AFib to address this problem of undertreatment of atrial fibrillation with anticoagulants. We did a cluster randomized study, as is often done for an implementation study. We randomized 50 centers in middle-income countries: Argentina, Brazil, China, India, and Romania. And we developed this intervention that included intense education and audit and feedback, and applied that to the intervention sites. Our primary outcome was the change in the proportion of patients treated with anticoagulants from baseline to 1 year, and secondary outcomes included stroke. Our main interventions included customized intervention at each country that targeted both the patient and the healthcare provider. We had a monograph, we had webinars, but then we had education at the point of patient care, so that we would review with these physicians, the National Coordinating Center would review with each physician the reasons that patients were not being treated, and then the educational messages around overcoming barriers to treatment. So our main finding was that, in fact, there was about a 9% absolute greater increase in the proportion of patients treated with anticoagulants at 1 year in the intervention versus the control. The most important single finding was that about half of patients not treated at baseline were treated at 1 year in the intervention group. And the intervention, in fact, was associated with a 50% reduction in stroke that was nominally statistically significant, p-value 0.04, but underscores the importance of this type of a program to not only improve care, but also to improve clinical outcomes. We targeted middle-income countries, but nonetheless, the centers that we targeted used by the end of the study, about 20% of patients were on NOACs. So it was predominantly vitamin K antagonists. The addition of NOACs to the equation, I think, adds even more opportunity to improve care, because some of the underuse of anticoagulation relates to specific limitations of warfarin. For example, some of these patients are simply unable to adhere to the regular follow-up and frequent INR checks and adjustment of the warfarin dose. Some may have concern over high risk of intracranial hemorrhage, where the NOACs have substantially lower risk. So I think the NOACs provide an opportunity to do even more to promote and obtain more consistent and comprehensive use of anticoagulation to prevent stroke.